This recording is part of a series of recordings covering the heart and the cardiac cycle. And this one is specifically going to address heart sounds. So the process by which a healthcare professional listens for heart sounds is called cardiac auscultation. They listen for changes in duration, timing, location, intensity of sounds, and they can use that to provide very important clinical information. So I want to do is review a little bit of the valves, because often when we're listening to the heart, we're trying to evaluate the function of the valves and if they're opening and closing properly. So as a reminder, your AV valves, your atrioventricular valves, include the tricuspid valve and your mitral valve. Tricuspid valve prevents backflow of blood from the right ventricle back into the right atrium. So when the right ventricle is contracting, you want blood to go this way. You don't want blood to go back up into the right atrium. So this is what we don't want. So tricuspid valves prevents that backflow. The mitral valve prevents backflow of blood from the left ventricle into the left atria. We don't want that to happen because we want blood to go out in this direction when that ventricle is contracting. Now the semilunar valves include your aortic semilunar valve and your pulmonary or pulmonic semilunar valve. And like all valves, they prevent backflow of blood. Specifically, the pulmonic semilunar valve prevents blood that has entered the pulmonary trunk from going back into, doesn't want it to go back in here. It should close. The aortic semilunar valve is there to prevent backflow of blood from the aorta, the ascending aorta, and prevents it from going back into the left ventricle. So one of the things that we will address, besides looking at the normal heart sounds, we'll also address if there's any valvular defects and how that can create some different sounds. So first, let's discuss your heart sounds. You have 4 physiologic heart sounds: S1, S2, S3, and S4. S1 is actually created by turbulence that generates vibrations that can be detected by using that cardiac auscultation. So turbulence creates vibrations that then can be deflected to the chest wall, and we can actually listen to these sounds. Well, and I should say all the sounds are created by turbulence. Well, S1 is created when the AV valves shut. So when the AV valves shut, blood is going to be redirected back down towards this area in the heart, and that happens at the beginning of isovolumic contraction. So AV valves close the beginning of isovolumic contraction. So it creates S1. Some people refer to it as lub. You're never going to call it lub. You're going to call it S1. That's the loudest and longest of all heart sounds. The AV valves are big valves. They need help from the chordae tendineae to stay closed, so that creates a louder sound. The second sound is S2. Some people call it dup or dub. That is created when the semilunar valves close. So when the semilunar valves close, that creates some turbulence, which creates vibrations, then we can hear it. Now that happens at the beginning of isovolumic relaxation. So we could also say that S1 signifies, when you hear S1, that signifies the beginning of ventricular systole. And S2, we could say that actually signifies the beginning of ventricular diastole, which that terminology will be important very shortly. Now S3 and S4, you notice they're not real big that you're seeing because they're not very loud. Lots of times you cannot detect it with the ear, but a phonocardiogram, which is a visual depiction of the heart sounds, can pick it up. But often it's not going to be audible. So, but an S3 and S4 are both created by filling of the ventricles. Now S3 is a ventricular filling sound that takes place during rapid inflow. When you have all this blood coming into the ventricle is going to stretch, and at some point it just kind of stops, and then that blood starts to slosh around and it creates a sound. S4 is a sound that's created during atrial systole. So this is when the atria are contracting to top off the ventricles with blood. And the genesis of it again, it's a filling sound, but the genesis is created because the ventricle is pretty full, and you're trying to push more blood into kind of a less compliant vessel or a chamber, because it's kind of stretched out already. So you have S1 and S2, which are created from closure of valves. S1 from the AV valves, S2 is from closure of the semilunar valves. S3 and S4 are ventricular filling sounds. They actually both take place during diastole. Rapid inflow for this one, and atrial systole for S4. Now I want to draw your attention over to this picture. So when a medical professional is listening to your chest wall and trying to listen for sounds, they're often going to evaluate what's up with certain valves, and where they're going to place the stethoscope over certain locations on your chest wall. Now the picture shows you the anatomical location of each of the valves. You see the smaller little circles, but where they place the stethoscope is slightly different. I want you to realize is the sounds associated with these valves are transmitted through bone and tissues and muscle, and again it gets deflected. And so where we place the stethoscope, it's where those sounds got deflected to. So they don't correlate directly where the anatomic site for those valves are. Now I do want to discuss where the stethoscope is placed for each of the valves. So I want you to look at the picture first. And so I want you to notice that the semilunar valves, the placement is closer to where the base of the heart is. So it's up here. The placement for the AV valves are lower down. So one of the things to keep in mind is the sounds associated with these valves follows the direction of blood flow. And so that kind of helps why you're going to put the placement in the right or the left when we look at a couple of these, and it's actually because it's following the direction of blood flow. So what I'm going to do is I want to remind you a picture of the heart, and I want you to show you that the pulmonary trunk right here is anterior to the ascending aorta, and bring your attention to the fact that the aorta is kind of coming behind this trunk here. It's going up this way, a little bit to the right, and the pulmonary trunk is up and going a little bit to the left. Okay, so there's a reason why I'm telling you this. So if we want to say what's the auscultatory site for placement of the stethoscope to listen to the semilunar valves, this is what they are. Okay. So if I go over here, go on this picture. So the aortic semilunar valve, the placement is right here, and the placement is second intercostal space, the right sternal border. The pulmonic semilunar valve is placed at the second intercostal space, left sternal border. So you don't put it on the sternum, you don't put it on a rib, because you're not going to hear it through bone. So it's placed between the ribs, and you notice it's either to the right or to the left of the sternum. So I'm going to write these down. Come here. So aortic semilunar valve, second, I'm just going to abbreviate, intercostal space is this, right sternal border. And for the pulmonic semilunar valve, second intercostal space, left sternal border. So remember I said These sounds follow the direction of blood flow. And I showed you the picture of the aorta, which comes up and a little bit to the right, while the pulmonary trunk goes up and a little bit to the left. So that's why it corresponds to which side of the sternum you place the stethoscope. Now these are high up near the base of the heart. Now if we do the mitral valve. Mitral valve is 4th to 5th intercostal space left of sternum, mid-clavicular line. Okay, 4th to 5th intercostal space left of the sternum, but it's not the left sternal border. You go to the mid-clavicular line. So let's go back to this picture here. So it's right there. So mid-clavicle. Pretty much it corresponds to about the nipple line. So that's where you place the stethoscope to evaluate the mitral valve. It pretty much is around where the apex of the heart is located. Now the tricuspid valve you see is over here, but the placement of that is variable. So for the tricuspid valve, go back over here. So tricuspid, that is 4th intercostal space. It could be left sternal border or right, depending on the individual border. So I'll give you the situation. It's not 100%, but it tends to follow this. If you have someone who's very tall, thin, and lanky, the heart tends to hang a little bit more down. The apex isn't pushed over to the side. I'm going to go back to show you this picture. So typically you see that apex is more this way, but if someone's really tall and lanky, it tends to point more down, so that's going to be to the right of the sternum. So 4th intercostal space, right sternal border. If someone is a little short, chubby, maybe put on a lot of weight, the adipose tissue and the gut and everything tends to push the heart more this way to the left, and so you may hear it better at the left sternal border, 4th intercostal space, left sternal border. So those are the placement of the stethoscope to at least to evaluate different of the valve sites. You're going to hear all those heart sounds at any of those auscultatory sites. Okay, so you're going to hear all of them. Or I should say S3 and S4 usually you don't hear. S3 can be heard in very young people. That sound starts to disappear in our 30s, unless you're like an endurance athlete or a female who's very pregnant. But after that, usually it's not audible. S4 is typically not audible. S4 can be completely normal, physiologic, and be audible but it's not going to be, shouldn't be audible. If you're under like 50, you should be, older people. But if you hear if there's an audible S4 in someone who's young, that's an indication of heart failure. Okay, but I don't have time to go through when S3 and S4 are not physiologic, but that's another story. If you're interested, I can talk to you about it at a later time. What I want to do is I want to just briefly introduce you to some valvular defects. So I'm going to introduce you to valvular defects, and in a subsequent recording, I'll go a little bit more in depth. And so there's two things I want to mention: stenosis and regurgitation. So if a valve is stenotic, it doesn't open properly. It's not fully open when it should. So it would create an abnormal heart sound. It will create a murmur during the point of the cardiac cycle when that valve should be open and completely open to allow that blood to get through. If you have a valve that is, we call insufficient or incompetent, All right, incompetent here. That valve doesn't close properly. So if during a phase of the cardiac cycle when that valve should be completely closed and it's not completely closed, you can get regurgitation of blood. You can get backflow of blood. So sometimes they call those defects regurgitation or incompetence or even insufficiency. So that's why I used all the terms. So in a subsequent recording, I'm going to cover the left-sided valvular defects briefly. So I'll talk about mitral stenosis and regurgitation, as well as aortic stenosis and aortic regurgitation. There are valvular defects associated with the right side of the heart, but I'm just going to address briefly the left side of the heart.